today and tomorrow in the future? What are we expecting will happen in the future? Again, not asking for these things. We're expecting them. We have to all start to expect better from patient safety. So we have just a panel of people who are going to bring us some absolutely fascinating perspectives on this question of expectation. So let me tell you who we've got, and then we're going to get started. First, we have Krista Hughes, who is a very good friend now, in addition to being she's a certified patient advocate. There is a certification in this. And she runs her own business called Hughes Advocacy. And she has literally taught me more than I frankly ever want to know about the journey of patients through the healthcare system. But she has more stories that are disturbing than almost perhaps anyone I've ever known. And you've been a champion for them, an extraordinary, really courageous in many ways in getting people the kind of care they need, no matter what it takes. And I really appreciate that. The kind of care they expect, yes. And then next we're going to hear from my friend Sue Sheridan, who is a new member of the Leapfrog board. She has a story also, sadly, to tell of a journey, several journeys through the healthcare system that did not go well, and has made her into a patient activist. She used to say advocate until she learned better, that we're acting, not advocating for action. So we'll hear, Sue has also become really a national leader as a patient advocate. Her expertise includes intersectional work with World Health Organization, the Gordon and Betty Moore Foundation, and other initiatives before she then joined the team founding Patients for Patient Safety. And I will add, she's also the co-chair of Leapfrog's expert panel on patients and families, in addition to being on our board. And then we have Robert Otto Valdez, and I'm very excited about Robert. Robert is the director of the Agency for Healthcare Research and Quality, AHRQ, another acronym from Washington. What is very exciting for all of us at Leapfrog when you started in your position is your passion around patient safety. I think it's really exciting that AHRQ has a leader who really understands that this is a priority issue. And you have brought such insight and passion, and you've brought people together and really been pushing so hard on patient safety. We really appreciate that about your leadership. Next, we have Sally Wellborn, another member of our board. She heads up Wellborn Advisory Associates. And she's a former executive in charge of global benefits for a number of companies, but most recently Walmart, which is, I believe, the largest, in terms of number of employees, the largest company in U.S. or the world, right? U.S.
At least the U.S.
In the U.S., a lot.
So is bigger.
Broad, vast experience as an employer leader who has always been attuned to the importance of quality of care as a priority, and has incredible innovations in getting employees there and helping to lead a corporate benefits program that actually puts the well-being of their employees at the absolute center of everything that you've done. And you've done some really great work, so we're very excited to have you with us. And then finally, we have my friend Barbara Wentworth. She is program manager at HealthNet and co-chair of our Partners Advisory Committee, and has been for several years, which we appreciate. Her leadership has really given us many good work groups and a lot of great output and important insight for Leapfrog that has led us in many new directions. So I really appreciated Barb's leadership, and very excited to have you here as well. So that is our panel. So let's start with Krista. What do you expect?
Well, first I want to thank you, Leah, for inviting me and to be part of this extraordinary panel. So it's not kind of what I expect. I want to speak more for the patient's voice. And it's what do they expect? And I'm going to ask all of y'all the same question that I get asked all the time by my clients. And it's, when is our voice going to matter and bring about change? I mean, think about that. Why doesn't our voice matter? Now, I know where patients are being heard. It's in everybody's mission statement, the vision statement. It's on elevator doors. But when are they going to start doing what they say? Now, I'm not against healthcare. I don't want anybody to think that. It's broken. But I'm going to be honest and transparent here. And in the 8 years I've been an advocate, 85 to 95% of the time, patients don't matter. Our voice, what we expect, doesn't matter. You know, it's actually the worst I've ever seen it. We could talk about all the data in the world. We all know it, preventable medical errors. So what I want to do is I want to give 2 patient stories, because I believe these stories, that if healthcare systems would learn from these stories, they would find the gaps and the barriers that would lead to the solutions to improve patient safety. In my opinion, the missing piece of the puzzle the last 22 years has been our voice. We are the data. I had a client, and he was on an event, and his family was out of town, and we were worried about a wound, so we called to make sure that they were moving him every 2 hours. And they said, oh, yes, ma'am. You know, we're following protocol. Now, he does have a little scratch on his face, but it's nothing. We got the wound care team on it. And so I don't trust the healthcare system. I knew they were taking pictures. I asked for the pictures. His scratch, I could fit my thumb in the side of his head. So because the wound was so aggressive, I asked for vitals. I wanted to know his white blood cell count, his temperature, all the numbers were going out of control. So then we called and said, we're really worried about an infection and sepsis. Well, that's when they got mad at us and said, you know, why are you questioning us? And he definitely doesn't have sepsis. 2 days later, he died of sepsis. That is a never event. And that is not transparency, and that is not what we expect. And then I have a client, he's 48 years old. He's got a rare heart condition. He's had 2 open heart procedures, and he has a pacemaker. And he had a pain block for some sciatic pain, and he called me a week later, and he said, I got a pain block. I know you told me not to, but now I'm in some bad pain. And I said, you're probably going to have to go get an MRI. So because of his rare heart condition, the only place he can get an MRI is at our local academic. So he went, and 3 days later, he was still in the hallway of the emergency department. And because I don't want to mess up his story, the first day he saw a doctor, and he was told, oh, you have an abscess on your L5 and a bacterial infection, you need a procedure. The second day, he saw a second doctor that said, no, you don't need surgery, but we are going to take blood and do a culture for your bacterial infection, and you're going to have to be admitted in the hospital, something's wrong. Third day, third doctor, they said, I really don't know. I think we're going to have to do another MRI. I think it's a spinal hematoma, but I'm really not sure. We're going to have to get you a fourth opinion. Well, the wife and I are doing all we can to get answers in this misdiagnosis, and why are we in a hallway? And so she reached out to the patient navigator to express her concerns about the quality of care he was getting. Well, lo and behold, what happened? His care was compromised. Later that night, he was discharged. No medicines, no antibiotics, no culture results, and told, just go to your primary care doctor, you'll be fine. 24 hours later, he called and he said, I am in debilitating pain, I think I'm dying. He went to a different healthcare system, a different ED. They treated the bacterial infection, got rid of his pain, and on Friday, he had a procedure for spinal hematoma. All of this, and I have so many stories, as Leah said. What they expect from us is to learn from these stories. I shouldn't be, Steve shouldn't be still talking about Judy Burroughs, except to honor your mother. But we shouldn't be having these same conversations without change happening. And what frustrates me and disappoints me and makes me so sad is that when we families express our concerns, for something they've done to us. We are dismissed, we're lied to, there's cover-up, nothing changes, and nothing happens to them. Where is transparency, accountability, patient safety? Respect, dignity, empathy, equity, that's all gone out the door. And we wonder why no one trusts the healthcare system. So I'm going to end with, what do we expect, Leah? We expect to be heard and change to be brought about. Thank you.
Thank you. Sue Sheridan.
Well, again, thank you, same as Krista, thanks for having me on this distinguished panel. And first of all, what brought me here was my family. Many of you know that my family experienced actually 2 medical errors. One resulted in the death of my husband when there was a malignant pathology that got lost and never communicated to his neurosurgeon or to us. And the other error was to my newborn son, Cal, who suffered brain damage when he was 5 days old from the failure to treat and test his newborn jaundice. So Cal lived through that, but he's 28, has significant cerebral palsy, many challenges. So that's what brought me here. Now, I'm part of a group called Patients for Patient Safety US. We have about 80 champions, about 30 strategic partners. Krista's a champion. Margot and Steve are champions. Marty Hatley in the audience is champions. We partner with Leapfrog, with HRQ, and many of you in the audience. And so we're really trying to develop this groundswell around patient safety. So in Patients for Patient Safety US, we've identified 5 threats. So I'm going to identify the 5 threats, and then I'm going to talk about what we expect about those threats. Threat number 1 that we identified, there is no one in charge in our country for patient safety, at the institutional level or the federal level. Threat number 2 is there is this assumption that the healthcare system can fix itself. We've been waiting more than 2 decades for change, and I think we have enough evidence to show that the healthcare system cannot fix itself. It needs us. The third threat is we simply don't have the right data to know the magnitude of harm or to fix patient safety. The fourth threat is truth-telling is optional when things go wrong. And the fifth threat is there is a lack of adherence to evidence-based practices, very much like Joe was talking about earlier today. So what do we expect? We expect that there is one person in charge in your institutions for patient safety and one national agency in our country that is accountable for reducing harm to patients. Right now, there is no one held accountable to make sure that we're not harmed. Number 2, we expect radical collaboration, meaning patient and family engagement with especially the marginalized communities, but we need patients and family members, communities, patient groups at the design table, designing the healthcare system based on the care that we expect to get, like Krista was saying. And I'm not talking about one patient on a committee. I'm talking about robust collaboration. Number 3, we expect absolute transparency. Again, I think we're all going to come back to this theme, including mandatory communication and resolution programs. It's absolutely unconscionable that today there's still cover-up when things go wrong, that we, the families, are not told. We expect to always be told the truth about the events that led to the harm to our loved ones, because we deserve it. We expect to always be informed of the reporting of that harm to the state, federal, and accrediting bodies, and the public, to signal accountability and to ensure that, to us, that learning will occur. We never expect the data and the learnings from the harm to our loved ones to be protected behind privileged walls of PSOs or other mechanisms. And we never expect to be prevented from sharing our experience of harm due to confidentiality agreements, because it is wrong to buy our silence when our experiences need to be shared for learning. We always expect that there are reporting and learning systems to which we can report harm. There's an example yesterday when I was sitting in the board meeting with Leapfrog. I got a text from or an email from a woman who went in for a hysterectomy. She came out without a uterus and a bladder. That is a never event. She has attempted to report that to CMS, to the Joint Commission, to her state, and there is no action and no response. So this is a glaring hole in our country. We have no place where patients and families can report a never event or harm. We expect that HCAHPS and other patient-reported measures implement the questions that we want to answer, especially about patient safety, diagnoses, and discrimination. Because without that information, the data on patient safety and equity is simply incomplete. And we expect the standardization of evidence-based clinical practices to prevent high harms. So many of the harms that hurt us are sitting, the solutions are sitting in journals on shelves. They are simply not implemented, and we expect incentives and we expect penalties. When there's lack of action on implementing those, we expect penalties. When there is lack of disclosure, we expect penalties. Most of all, we expect courageous leaders who are unwilling to accept the status quo. They are unwilling to negotiate our safety, but they are willing to step into a new paradigm where they're creating and designing the healthcare system with the patients and families. Thank you.
All right, Robert, what's the federal government expected to do?
Well, thanks very much. And I'm not sure if it's what the federal government's expected to do, but to answer the question, what patients and employers are expecting, because what some of you may not know is the Agency for Healthcare Research and Quality is one of four the science agencies in the Department of Health and Human Services. We're the smallest. Most everybody knows our big brothers and sisters, NIH, CDC, FDA. They have regulatory powers, they have sort of big money, but we're expected to do a unique mission, and that is to improve healthcare in the United States for everyone. But we're expected to do that in partnership with people like you, with hospitals, with clinic administrators, with clinicians, with, most importantly, patients and consumers who can express their opinion and to drive the improvement in care. The actionable knowledge that was talked about is part of what we try to do. Unlike our colleagues who are at the other end of the biomedical research world, we're in the health services research world, which looks at how things actually operate in what our colleagues at the National Academy of Medicine say, the real world. And so we are actively looking at how we take discovery and make sure that it gets into the workplace and practice, which is why the work of Leapfrog is so important. I want to tell you a Leapfrog story because it's the story that has allowed us at the Department of Health and Human Services through Secretary Becerra's leadership to put patient and workforce safety back at the top of the agenda of the department and of the administration. About a year ago, we had an opportunity to meet with the healthcare executives of the 25 largest health systems in the country. And they made two requests. One was an opportunity to create a national forum for learning so that they could share best practices and so that that could accelerate their ability to try to be responsive to what finally was being recognized publicly, and that is that our healthcare system is in crisis. You've already heard 1 in 4 people who walk into a hospital experience some kind of event that should never have happened. They're preventable. We have the knowledge and know-how to make things right and to do things right. But first and foremost, it requires a real organizational culture that recognizes that quality and safety are primary to the function of the organization. And that every member of that organization, whether it's the highest paid clinician to perhaps the person who takes care of maintenance, every person in that facility has a role to play in safety. Everybody has a role to play in understanding and recognizing the hazards that exist in the field and in the delivery of services. That recognition, I think, is finally coming to the fore. And as we met with the largest health systems, we not only had the healthcare executives there, but we also had their board members. And to be quite honest with you, I served on boards around the country, both hospital boards and other executive corporate boards. And this is the only industry I know where the board and the executives aren't focused on the quality of their product. We've got to focus on the quality of our product. And so I think that patients and employers, when they buy services from us as a service industry, they expect us to be focused on the quality of the product they receive. They expect to walk into a facility and not be harmed for one reason or another. And many of them are not intentional. Most are not intentional. I would say 99.9% of the time they're not intentional. But we have a system that is far more complex, fragmented, that can be fixed. ARC has illustrated with its own work that as you focus on implementing these evidence-based practices, you can make slow but steady improvement. Unfortunately, we can't and have not studied every possible thing that goes on in a hospital, and many things that used to take place in the hospital no longer take place in the hospital. So Leah, your question, are you only focusing on hospitals? Not at ARC. We're looking at the entire span from when you actually begin to think about having an appointment, because that's when your journey begins. You know, today, most younger people, they go on the website first to check out what's available, what does Google say about what I'm feeling and all those other things. That's the beginning of your patient experience. When they go onto your facility website to look for information, that begins the whole process. The upshot of the story of meeting with the healthcare executives and the board members of those 25 largest facilities, the secretaries charged the department as a whole with our coordinating to focus on developing a national alliance for healthcare safety, both for patients and for the workforce. And over the course of the last year, we've been working on that, aligning the forces. And last week, the American Hospital Association announced that they're aligning their efforts to have a full focus on patients and workforce safety. So we're also been working with the accreditation bodies and with others to align this effort so that we actually have a full focus nationally on improving the patient safety situation in all facilities, not just hospitals, but across the spectrum of healthcare delivery.
Thank you. That is highly encouraging. All right, Sally Wellborn.
All right, so first of all, I want to acknowledge that I could never say as eloquently as Krista and Sue did what employers want, which is for every person that walks through the doors of a hospital facility to walk out better than they walked in. So just putting that first. But I want to also say that from the employer perspective, I know you think all we worry about is dollars and cents, and I'm going to let you continue to think that, because truthfully, there is a financial consideration here that America is paying a lot more for healthcare per capita than most other industrialized countries. A lot of reasons for that, some of which is we're paying for things that should never have been done or should not have happened. So for every event that they described, some family had out-of-pocket expenses, some employer, potentially if they were employed, had dramatic expenses, and net cost to us as a society is dramatic. So while it is, employers expect that you are thinking, that hospitals are thinking about this as a system. None of us are on an island operating independently. It impacts everything. When healthcare costs are higher, it means there is less expendable income for every other thing that happens in our society. And when you think about it as your profit margin for the for-profits or your reserves for your not-for-profits, then you aren't thinking about that patient and the payer. So what employers expect is that it should be a mutually satisfying business relationship. Everybody has, we are in a capitalist country, appreciate that. And we absolutely want our hospitals to succeed because we want the world-class hospitals. We want world-class hospitals, full stop. And in order to do that, you have to make money. So I would also say then, in aligning with what Dr. Valdez said, which is that when your board is meeting and you're making your annual decisions about where to invest, how to create your budget for the following year, the first investment is probably not how are we going to upgrade the entrance to the facility to make it more inviting to the people who have more discretionary income. The first investment decision should be how much more are we going to invest in safety and in patient improvement. So Leapfrog was started by employers. I don't know if you all are aware of that, but our history is that it was employers that got together and said, we're paying for healthcare that isn't working. What can we do to change it? And we said, let's shed a light on what is wrong. And that was how Leapfrog was started, and through everyone in this room that participates in Leapfrog. We now have improved safety, and Leah has talked about. Can see there have been leaps. But I feel like I'm sort of preaching to the choir in this room. You guys are the good guys. You guys are the ones that are at the top of the list. You have made improvements and strides in improving safety. So take all this with the fact that I respect that. This is the cream of the crop with respect to safety. The problem is your industry is not the same. And when I see an article in Modern Healthcare that says that hospitals are alarmed that they may not make as much money because they're going to be measured on their sepsis, how well they do at sepsis. Like, seriously? That's how your hospital association responds? Is like they are afraid of losing money because they aren't managing sepsis? So your voice as the leaders in your industry is your opportunity to make a difference, not just at your facility, but at every facility in the country, because you guys are the good guys. You guys are the ones that need to be the leaders and make that change, as opposed to just competing with each other on how can we get one more patient in the door. It's about how can we compete on make safety better in America.
I have to say, I really appreciate that call to action by our top hospitals. I really think that's a powerful message, and I hope all of you can take that to heart, because that is true. Our top hospitals, we're so proud of you. We want you to go out and make this change. So thank you, Sally.
Leah, real quick. False alarm.
Thank you.
Good. Thank you. Barb.
Great. Thank you. And I'll be speaking as a California health plan, and we work with hospitals on patient safety on behalf of both patients, our members, and employers who represent our large commercial accounts. And while we do monitor individual safety events, a lot of our work is really on all payer data. And so we want to know that when a member goes to one of our network hospitals, that they are cared for in an environment that prioritizes safety, a culture of safety.
Go ahead, Barb.
All right. we want to know that our members are going to hospitals that prioritize safety and that have the systems in place to help yield those best possible outcomes. And while we do think it's important that individuals are informed about hospital quality, and we do encourage our members to use hospital quality in their decisions when they're selecting a site for care, we would rather not place that onus on the individual. And when we think about when someone is choosing a hospital, there may be a range of limitations in terms of their region, what their local options are, their particular plan and what's covered, their provider. And I also think about the emotional state of someone who's looking for a hospital for a procedure that they wish they didn't have to get. And that can be a scary and uncertain time, and a lot of quality data is complicated. I think the safety grade is an exception, and that's one of the reasons it's so important, is because it is so accessible. But we as a plan want to do that work up front to work towards every door leading to a safe environment. And so that's the goal. And we do that by engaging with hospitals to convey our expectations about measure performance, helping to connect them to the organizations that can help them improve, and then helping to hold them accountable for that progress. And we do that by engaging with them, talking to them, through financial incentives. And then we also provide our contracting team with quality information that they can use to inform their negotiations. And we know that this is not a quarter-to-quarter project, that this is about sustainable progress and long-term gains. We're a California plan. We have hundreds of hospitals in our network. And so we do see considerable variation. And as you all know, it's typically not all poor and all really great. I know there are some hospitals here who represent that level of excellence, but in general, it's a mix. And so we're working to reduce that variation toward better performance and fewer outliers. And I think an important, or sort of an interesting context for our hospital quality work is our state exchange. And in California, we have quite a robust state-based exchange with an ambitious quality agenda. And it includes requirements for all participating health plans, there are just under a dozen, to engage on hospital quality in the areas of patient safety and maternity care. And those requirements have changed over time, and plans vary in terms of their level of engagement. So there's a lot more work to do. But I think it has led to health plans engaging in a way that many had not previously. And it's just sort of interesting from a policy context because in our state, the state exchange represents a pretty small slice of the overall population. But because these requirements apply to all payer data, to all patients at a network hospital, and because we have such a robust exchange, our networks reach virtually every hospital in the state. So you have this pretty small part of the overall health insurance pie that is helping to drive engagement across the hospital landscape. And I think those requirements have helped to create an environment that's really ripe for cross-organizational relationships. So we work very closely with data organizations, with QI collaboratives, even other health plans, because we all have an incentive to work together. And I'll just give you an example. We felt that it would be appropriate for the exchange to gather health plans to combine our efforts in this work. In particular, we've found that it can be quite difficult to engage some outlier hospitals as a single plan. And the exchange has not taken up that role as a convener. So we connected directly with some other health plans. And so we're all working together to engage a group of lower performing hospitals in Southern California. And we need to keep pushing that work forward, but I think it's a model with promise, I think. And I think that, that element of creativity when we hit these roadblocks is so important, whether it's, a state-based exchange, finding a way to expand its scope to work towards improving care broadly, or health plans, building these new bridges. We know the status quo isn't working, and so we need to try new things.
Thank you. Appreciate that you have been very active as a health plan, impressively so. So thank you for sharing that. So I'm going to ask a couple questions, and then we'll open it up to the audience. But my first question has to do with technology. is there anything that, from your perspective, we should be expecting from from new technology that's emerging, such as AI, but not only AI, just new ways of communicating with patients, new ways of communicating internally within healthcare settings, new ways of new kinds of devices and information? Has any of that dazzled you and you've thought, oh, that's where the future needs to go. That's what patients and employers want to see. EMRs.
Are you asking the panel or?
I'm asking everyone, but I'll start. Since you spoke first, Robert, you get to go first.
I will, and I also promised a leapfrog story.
Yes, that's true.
Before I was interrupted by a fire alarm. So I'm going to start there because it actually leads into this. And that is, as I was presenting issues around patient safety in the department about a year and a half ago, and our concerns about what was happening during the pandemic, I was able to tell the story by illustrating that progress is possible. There was a hospital in California that has consistently scored C-level safety grades 5-6 years in a row. Pandemic hit, guess where they went? Down. They were at D level reporting. That facility had this consistently low performance, but was owned by an organization that didn't make the culture of safety part of their organizational culture. That facility was purchased by another organization where the safety culture of their organizations were at the top of what they do. And in a year's time, they went from D to B. You can see change. Part of that change is in your hands as leaders. It's the organizational culture that drives those improvements. And that organizational culture includes hearing the voice and responding to the voice of our consumers. And that's why that 1 in 4 person who walks in who experiences that negative outcome that was unintended doesn't have to be. We actually know how to do it. We know how to be responsive. We actually can become even more advanced looking with some of the technologies you're talking about. We've been talking with a number of organizations to figure out how to get tools that we have and make available to the public, to boards, into the hands of people more readily, and into the consumers in particular. So, for example, some people have watches that sort of buzz when they need some kind of service or when they need to take their medication or what have you. We're also the home, the Agency for Healthcare Research and Quality is also the home for the U.S. Preventive Services Task Force. And so there are a set of recommendations and high-level recommendations for preventive services. There's no reason your watch shouldn't tell you, yeah, you're due for your immunization. Make your appointment. And so trying to find those kinds of cues, use those new technologies to both inform the consumers about what they should be demanding, what services they should be asking for. We also have an app at ARC that's called Question Builder. Please use it, download it. It's one of the best ones you can get off of the Apple Store and the other stores that help you prepare for that 15 minutes that you have, that precious 15 minutes you have with your clinician. You want to be ready to ask those questions and know what you want to know, and it helps you do that. Krista, I know, uses it with all of her clients. So.
Great, thank you. Sue?
Yeah, a comment about technology. I just want to share that, AI is on the, it's what everybody's talking about right now. And I want to share that Patients for Patient Safety US has actually a working group around AI. And I'm hopeful that a paper will be coming out soon about AI, and that we see a lot of opportunities with AI. But we really want to ensure that patients and communities are engaged in developing those algorithms and ensuring that there's ethics infused, ensuring that humanity is infused in AI. I mean, we see a lot of wonderful opportunities regarding diagnoses and early warnings. And one particular project that I really like, I think it was called Patient Advisor, that would empower patients with their own data real time. And it would help you, Krista, as an advocate, that it comes to the patient on a tablet. This was a project that was in part funded by Beth Daly Ullum, who was also part of Patients for Patient Safety US, where the patient would get their own data, you know, while in the bed, and that the AI would actually give the patient questions to ask. And that, you know, I thought about that, and I thought, if only I had had that. If only I knew my son was visually assessed to be jaundiced at 14 hours, and that is a huge red flag. Had AI told me, Mom, ask this, ask this, ask this. You know, same with Pat. So I think there's some wonderful projects out there that we can harness AI and technology, but I also don't want technology to replace our discussions in the fundamentals of patient safety. We can't leave culture and transparency and the other things that we have not solved in the past 20 years. We can't just say, we're going off here with technology. We have to, you know, stay where some of our true problems really lie.
Yeah, technology will reflect the people who in the institution.
Can I just add one thing on that? So I think the challenge for me in thinking about this question is parsing the people that are delivering the care from the hospital system. And because I can't. I mean, in my mind, you know, I'm just I'm not of your industry. So to me, it all kind of gloms together as the hospital, right? Which is all the people in it that are delivering care, the nurses, the doctors, as well as the facility and the ownership of the hospital. But I think about, so I work very closely in the innovation space and work with a lot of innovators that are creating a solution for everything, some of which is garbage, but some of which is really, really great innovation. And they're selling it first to employers because they know that employers are interested in making a change and are willing to invest in it. But they also sell to health plans and they sell to provider systems. And quite often in the conversation, what I hear in the provider systems and the health systems area is the first thing is, well, this actually won't help me make money, so I'm not interested in innovation. So kind of changing that dialogue about how is this going to improve care is important. But technology doesn't have to be like sexy and some AI-driven thing. I heard about it's a simple calculator that was created by a researcher that could be implemented or inserted within your EMR that calculates the probability or the likelihood that a mom coming in would absolutely need a C-section. And it's probably got some really high PhD level stuff inside of it, but it's a simple system on the outside when you look at it that you input a few key elements. And what it was implemented in a couple of hospitals, and what they found was when the doctor was able to see that truly this patient is probably not intended to going to need a C-section, they were less likely to actually use a C-section. And we all know that C-section rates are too high in this country, a clear, specific patient safety issue. And so it doesn't have to be sexy innovation or sexy technology, but it's even simple technology that you can insert within to make things simple. I mean, we have human beings that are delivering care that are busy. And so if you can insert things into your system that take the doctor that is intending to do well, but there are errors that happen because they don't have information, to the extent that you can insert that to make it easy, it's routine, it's default. So getting defaults, any innovation that can get the default thing to do right, where it's hard to do wrong, that's an innovation that should be invested in.
Well said. All right, we're going to open it to questions from the audience. And while we're waiting for people to get to the mic, I have a question for Krista. In the stories that you told about these, your clients who went through some pretty awful experiences, what would you have preferred? What should they have encountered when they went through the, like one of the clients you mentioned? What would you have wanted them to encounter instead?
One, they don't listen to us. That's the biggest, as an advocate, the biggest, I guess, makes me the angriest is how they dismiss us and don't listen to us. Our concerns just don't matter. You know, hey, are you lying? Are you changing the patient every 2 hours? Oh yeah, we know that's protocol. I would rather them to say, you know, we hadn't, or oh, we forgot, or, you know, we have found a big wound. And go, why did I have to find out from a, you know, actually we went behind the scenes to get this picture. They didn't want us to have it. I shouldn't have gotten a picture of a hole. They should have been open and transparent. And then it drives me nuts that they don't learn from it. They sweep it under the rug. Nobody gets in trouble. I reported this to CMS and Joint Commission, and all this just got thrown out the window. And all of my stories, that's how we're treated. I'm just sick of them not listening and lying to us.
You know, it's interesting because I think a lot of health system leaders that I've spoken with sometimes think, well, what must bother patients the most is that we make these mistakes, and they're horrible mistakes, and we don't like to sometimes talk about how bad these mistakes are. But what you've said, and I know what Sue has said so many times, is really it's about listening. It's about the fundamentals of listening, apologizing, being honest, even when you made a big mistake. So it's not that patients don't forgive the mistakes, although they are not something we want, nor should they happen often. But the biggest problem is the dignity of the patient and being treated that way, which I think is an important lesson to be learned.
And Sue said it, and I agree with it. The family who lost their loved one said, why did they just not apologize? And why won't they learn from it so this doesn't happen to somebody else's parent? And that's what bothers patients the most is, I mean, I'm gonna be honest, I've begged hospital systems to bring me on as a patient advocate to tell you gaps and barriers, and they won't bring me on. You know why? Then they have to be transparent. Then they'd have to open up to, oh, we've made mistakes. Mm-hmm. Then they have to be honest about it. And that's what bothers me is if you really want to change it, you're really gonna have to co-design with patients. You're gonna have to be vulnerable, and you're gonna have to learn from us.
And I think in this audience, there's some hospital systems that I know are much better at that.
Oh, well,
so
yes.
We're gonna learn from you, and hopefully you can educate your colleagues as well. All right, who has a question? Okay.
Hi, Patricia Kelmar. I'm with US PIRG, the Public Interest Research Group. We're a consumer advocacy organization interested in high-value healthcare. And I know that there are a lot of hospital leaders and government people here who have the power and the interest to make the system work better for patients. But I think what we're seeing today with greater consolidation and seeing larger entities come in and buy up, local hospitals and local physician practices, we're bumping against the ability to maintain good patient care or spend the energy and time to really look at how to improve patient care, and the need to turn profit for the new corporate entity that owns these care facilities. And so I would just, be interested from a health plan perspective, from, the federal government agency perspective, what kinds of things do we need to put in place to maintain the ability of local leaders in their healthcare facilities to be able to stand up to that kind of corporate pressure to increase profits at the expense of patient care?
Thank you for that question. Dr. Valdez, I'll just share. I think that part of this is really elevating quality in terms of, the need for each of these facilities to be responsive to other stakeholders. And so I think, the work that we're doing as a plan really in response to our exchange, some of our large, CalPERS, other, major stakeholders in our state, for example, where they want to see those results. And it's both sides. I think we want to see high performers, and then we want to eliminate those low performers. But I think that's in terms of the internal workings of your organizations. I wouldn't be able to comment, but I think that's what we can do, is to say, we're purchasing services from you in various very complicated ways in our delegated system, but we need to see that these data are meeting our expectations.
Would you agree with that, Sally, from the perspective of the employer?
Well, we share your concern about consolidation. I don't know if, to be honest, I don't know whether federal legislation or state legislation could influence this. It could, I assume it could or would. I don't know that I've ever seen. I'm not a lobbyist, so I don't know what legislation there may be that would require in those consolidated systems to be able to do exactly what she's talking about, which is to eliminate the rules about if you have one hospital in the system, or if you want one hospital in the system, you have to have all hospitals in the system. So all of those kinds of rules, those are the ones that cause us problems. It's not, yes, it's an and around the consolidation with respect to financially, it confuses the questions, but more importantly, it comes back to the transparency part, right? Because we can't get transparency at an individual hospital level, and then we have to negotiate for all 175 hospitals in the system, like that, when there is variation. I think that's.
And reporting at the individual hospital level, by the way, is in that PCAST report, and Sue is on that PCAST work group. Thank you. And that was a very important provision we consider that extremely high priority provision that was in that as a result of just the point you just made, Sally.
Leah, can I just jump in? We haven't talked about equity, and I just wonder, and I know that was a big topic in the PCAST report.
Yes.
I think that in terms of transparency, that's something in the hospital quality arena that we can really improve on. As a plan, we're doing so much equity work on the member level, and you all are doing some great work in terms of C-section rates, for example, where it's so salient and critical. But I think that's, we don't have sight lines into that in terms of public reporting, and that will need to change.
Thank you for bringing that up. We also have a report that we did with the Urban Institute that's out on our website about the disparities in a number of patient safety events, and they're disturbing disparities. So, and within hospitals with the same patients with the same payer. So, very much a clear equity issue that is related to patient safety events. So, definitely, please look at that as well. All right, I think we have time. Yeah.
Hi, Leah.
Hi.
Thank you for teeing up my question, because I was going to cite your study, the disparity study, and I wanted to ask what role nurses have in addressing health equity and in achieving health equity, and especially about creating a more diverse nursing workforce that reflects the communities being served.
So nursing, most of what hospitals do is deliver nursing care. So when we talk about patient safety, we actually really do have to talk about nursing, and we have to understand that. I think I'll ask Sue and Krista, from your experience, what would you like to see from nursing specifically?
For patient safety?
For patient safety.
Which is like the healthcare system. There's the good and the bad.
Right.
Now, my client that I was telling you that's 48 years old, that was just in the hospital. He was in a lot of pain, and the doctor prescribed a medication that he didn't need, where he couldn't tolerate, and the doctor argued, and the nurse felt sorry for him and went to another doctor and got him something different he could tolerate. And the nurse was harassed for that. And he felt sorry for her, and the client did, and he said, "I'm so sorry." And she said, "I can take it. It's how we're treated these days." But he said the horror in her face when she came and yelled, and she said, I care about patient safety and you, and that's all. So nurses are treated either bad or they are bad. So it's 50-50.
Something, and this is based on a story, but something I'd like to see for the nursing profession is that they are more empowered and that they are part of the diagnostic team, and that, and the example that I'm going to give you is my son, Cal, when he suffered his brain damage from his newborn jaundice, the nurses noted his newborn jaundice, and they were the eyes and ears for the pediatrician, and the pediatrician ignored them. And so when a group of moms got together, all children with brain damage from jaundice, known as kernicterus, we all got together, and across the board, all of our stories were the same, that the nurses identified the jaundice early. They tried to alert the healthcare system, and they were ignored. So when we went forward our mission was to change the standard of care. And so our first stop was the Joint Commission. And so at the Joint Commission, we wrote together, it was their first sentinel event alert created with patients. And so we moms said, we want in the sentinel event that the nursing profession is empowered to take a bilirubin without doctor's orders. And that's the first time that the Joint Commission ever did that. And so we immediately saw how they are the front line. We relied on them. And actually it was the nursing profession that joined the mother group, and they were first to come out publicly with a position statement about a universal bilirubin. So I saw this courageous profession that can contribute so much more to patient safety if we create the policies and the standards that elevates them to really be part of patient safety and part of the safety team.
And that is why it is on our safety day. Okay, well, we are out of time for this session, and we could go on for a lot longer. This has just been extraordinary. I really thank you. You have been an amazing panel. Thank you so much for your insights and really sharing your heart with our audience.
That was just terrific. For those of you who don't know my story, just to be in this room with all of you and with this panel right here, for 10 years I was surrounded by people in my mom's care that just did not care. And to see so many people in the same place that care so much is so unbelievably invigorating and hopeful. And thank you.